I'm Bernard Gersh, consultant in cardiovascular diseases at the Mayo Clinic and professor of medicine at Mayo Clinic College of Medicine. And this interview is really based upon a review that I've just published with some of my colleagues, both in the clinical and the basic sciences on stem cell therapy or cell repair therapy, a clinical perspective. And it's really a review of stem cell therapy from a cardiovascular standpoint. Embryonic stem cells, of course, are in a way the prototype of a stem cell. An embryonic stem cell certainly can form a cardiac myocyte, but it can also become a tumor cell. An embryonic stem cell is a little like an undisciplined child. You don't know quite direction it will go. And so some of the work done at Mayo Clinic by Dr. Andrei Terzik and his colleagues, and he's one of the co-authors of this paper, is to take these embryonic stem cells and guide them down a particular developmental route. So as to take these cells and basically treat them with a number of molecules so that they become cardiac cells and not tumor cells. So that's a very interesting group of cells. Now, a tremendous amount of interest in what are called mesenchymal stem cells that are more primitive than the adult bone marrow cell. Not as primitive as an embryonic cell, but they are more primitive cells, and they've now been tested in clinical trials. The first clinical trial is now ongoing on using what are called resident cardiac stem cells, and these are stem cells that appear to reside within the heart. We don't quite know what they do and why they're there, because they're obviously not enough to heal the heart after a myocardial infarction. But they're there, and of course that's of interest, because if we can culture them, which can be done, and clone them and give them back, maybe they're certainly promising for repair. It's interesting that fat cells, adipose tissue, is a rich source of perhaps mesenchymal stem cells, and also maybe a rich source of a completely new technology, which is to take adult cells and reprogram them back to being stem cells. And it appears that just in the last week that one group has been successful in taking adipose or fat cells and reinducing them or reprogramming them to be stem cells. And of course the attraction of adipose tissue is, that it's in no short supply in all of our society. And then this just incredible series of experiments that are done in the last year, which is called the induction of pluripotent stem cells. Now, to understand what this is, this technique takes adult stem cells, fibroblasts, from the skin, or as I mentioned, fat cells, adipose tissue. And then by genetically reprogramming them, it takes this adult cell and turns it back into a stem cell. Of course, this avoids all the huge social and ethical implications of embryonic stem cells, because that is a very legitimate debate. I mean, people have very polarized views about embryonic stem cells, and it's not going to go away. It's a very legitimate debate. So this technique of induced pluripotent stem cells is fascinating. And what is so exciting about it is within, I think, weeks or a few months after the original experiments in Wisconsin and I believe in Japan, University of Wisconsin in Japan, everybody else who tried this has been able to reproduce it, including our own laboratory. So there are problems, because these stem cells, again, have the ability to go in different directions. But I think that's something one should really follow. It's very exciting. Well, I think that all the animal and preclinical studies have been extremely promising. It almost too good to be true. It doesn't matter what cell you use, it appears, what dose, where you give it, when you give it, how you give it. Every, just experiment after experiment, study after study, shows an improvement in cardiac function, contractility. Some show an improvement in blood flow. It's like everything works, and that's part of the puzzle, because we know that these cells do not survive. So really, what is going on? I mean, it's overwhelming preclinical and animal evidence of benefit. And one of the explanations is that the cells don't work for the reasons we think they do. What we would like to do is put the cells in, have them replicate, generate new muscle cells, and that's the theory, that's the hypothesis. But there's now another concept that's perhaps pervading, the so-called paracrine hypothesis, and that is that it's not the cells that replicate that result in the improvement in cardiac function. It's that these cells secrete proteins and molecules that in themselves may have a beneficial effect on contractility, on metabolism. The so-called the paracrine hypothesis. Sort of quite fascinating, really. I mean, it's almost like you would milk these cells like you'd milk cows. You'd milk the cell for whatever it is they produce, and then that's what you'll give. Now, I don't know if it's going to work out that way, but certainly at the moment, what we have to say is the degree of benefit appears to be out of proportion to the numbers of cells that we inject and their ability to survive. So other mechanisms prevail, and it's fascinating. It's part of the major interest in this whole field. Now, and the same things happen in the clinical arena. There are modest benefits on function, but the cells don't survive. Now, it may be that in 10 years' time it's different. There are a lot of barriers set up that do not work in the cell's favor. Inflammation, scarring, just a whole host of barriers. And so it's not surprising, perhaps, the cells don't survive, or at least in the quantities we would like. Now, ongoing research is attacking those barriers, and it may well be that new techniques are found that enhance the survival of cells, and then the mechanism of benefit will swing back again. Right now, it's the paracrine hypothesis. It could be in 10 years. In fact, it may be cell survival again. Having said that, I mean, the trend is always towards the positive, by and large. The worst I've seen is neutrality. But the majority of studies, vast majority, are positive. That's in the animal and preclinical. Now, in the clinical studies, the benefits, one has to say, are modest at best, but always in the right direction. There are people that feel strongly that it is absolutely premature to be doing the clinical trials that we do, given the fact that we really do not understand how the cells work and the mechanisms of benefit. And I mean, that's a fair viewpoint. Now, the counterpoint to that is there are many precedents of clinical trials providing answers providing answers that generated new questions. And let me give you an example. Aspirin was around for 100 years before we knew its benefits on platelet function. The angiotensin-converting enzyme inhibitors, the ACE inhibitor drugs, they are blood pressure lowering drugs. We've now found out, as a result of trials, that some of their major effects are at a cellular level on the basic pathophysiologic aspects of atherosclerosis. We wouldn't have found that out if we hadn't have done the trials. I can understand the opposition to trials. Equally, I would argue that every trial has either been neutral or positive, not harmful. And that, in a way, is a stimulus to do further trials. What I think is important is that if we run away with ourselves and we do huge multi-million-dollar trials and they're negative, we will kill this field. Because funding, it's like international capital. Funding wants a return on its investment. And the funding agencies do not want to fund negative trials. So I think what's really important is to be modest about the trials, is for clinicians to work with basic scientists and to design trials that are really focused, that answer specific mechanistic questions. What cells, what dose, where should we give them, when should we give them, how should we give them, what adjuvant therapies can we do? Just chip away at this bit by bit, chisel away, to try and do a 50,000 patient a trial based on mortality and heart failure would be premature, and I wouldn't want to see that. So I think we need to do small, focused, mechanistic trials. Now, 1 or 2 trials will be bigger, and there's one being set up in Germany that's looking at clinical endpoints, and that's fine. I think that's fine, but the bulk of the studies in the United States and in Europe are going to be, I think, much more focused and mechanistic. It's not as simple as we thought it was. This is not going to be a part of our routine clinical armamentarium tomorrow, and we need a lot more answers. But I would fall on the side of people who say we should continue with trials, but be very specific about what each trial, what question is going to be asked. About 5 years ago, the House of Lords in the United Kingdom had a committee to look at science, the House of Lords Select Committee. And there's some interesting statements that came out of it. And really, others have pointed this out too, that the public's understanding of science is often inadequate. But as scientists, our understanding of public perceptions is often inadequate. And I think what came out of this committee was, as we get into these areas of cloning and stem cell therapy and pretty fundamental issues, there is a real responsibility to engage the public. After all, this is done on taxpayer money. I mean, this is not just a simple experiment. I mean, we're out there in the very much in new territory, and I think it's really important that both from an ethical and another standpoint, that the public be fully engaged. I think the phrase that was used, which I quite liked, was, I think involving the public in the decisions is something like the social equivalent of informed consent. Nice. I don't think I quoted it exactly right, but a nice turn of phrase. So I think what is important, I mean, we read in the papers that stem cell therapy is here tomorrow. You know, why is the administration not funding it? I mean, we have a cure for Parkinson's disease, we have a cure for paraplegia. It's not there. It's down the line, and it may not happen, but it may. But it's our job when that comes to be sure, when we read those kinds of articles, to be sure that there's responsible reporting. I think that there is now a massive worldwide effort to expand and understand this technology. It may bear fruit from a clinical standpoint in the future. And we simply don't know. It is too early to accept that this is going to be a routine part of what we do clinically in a year or two. Far too early. It's down the line and in the future. What I'd say, though, to patients and to physicians who may not be particularly interested in the field, don't ignore it. I don't think it's going to go away. I hope it doesn't. You don't have to become a stem cell biologist, but watch it, even if it's from a healthy distance. But I would just stay tuned.
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.